Go ahead and get started with the webinar presentation today. My name's Kate with the Patient-Centered Primary Care Institute, and I'm just going to go through just a couple of things before we get started with our presentation today. So because there are a great many of you on the line and joining, we have everyone on mute throughout the entire presentation today. We did set aside time to take questions. We hope it'll be about 15 or 20 minutes, but we'll see as we get through the presentation. It would be great if a question occurs to you throughout the presentation, you can type it into the questions pane on your GoToWebinar control panel. When it comes time for Q&A, we'd love to be able to unmute your line and have you ask your question directly. So if you're in a position where you can do that, it would be great if you could let me know that in the typed question pane, and we will unmute your line and allow you to ask the question. If you're not in a situation where you can do that, you can go ahead and type your question and I'll read it to Ann for you. The one question I can always anticipate is about the slides from today. The slides along with the recorded version of the webinar will be posted to our website by 5 o'clock today, and then we'll also email a copy of the slides and a recording of the presentation to everybody on the line today. So before we get started, just a couple of words about the Institute. The Institute was launched last year as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and the Oregon Healthcare Quality Corporation. And our goal is to facilitate access to a broad array of technical assistance for primary care practices that are at various stages of transformation through web-based resources, much like this webinar, and other training resources and programming, with the goal of building capacity and creating alignment around practice transformation and quality improvement in the state of Oregon. We definitely encourage you to visit the Institute website to access resources, including recordings and slides from all of our previous webinars since January, and registration for upcoming webinars. Really briefly, the Institute aims to help primary care practices achieve recognition as a primary care home through the state's Patient-Centered Primary Care Home, or PCPCH program. And what you see on your screen are the PCPCH model's 6 core attributes. And within each of those attributes, there are standards that help the state recognize primary care homes. You can visit their website at primarycarehome.oregon.gov to learn more. And just a couple of acknowledgments before I turn things over to our presenter. This presentation is based on a similar presentation delivered through the Comprehensive Primary Care Initiative. Several community partners contributed to it, and so we wanted to acknowledge them here. I'm going to go ahead and turn things over to Ann. Ann is a nurse and certified diabetes educator who has worked in a primary care setting for more than 15 years. She's presented on and taught care management throughout the country, and we're very pleased to welcome her here to the webinar today to do just that. Give us just a moment to hand things over to her, and we'll go ahead and get started.
Well, thank you for inviting me to share my experience as a care manager. I left the hospital care management almost 20 years ago, quality management, care management, to go to a primary care setting. Currently, the practice that I am in is a primary care clinic with 9 providers, which includes, well, the 7 primary care physicians, 1 nurse practitioner, and 1 PA. And care coordination is a huge part of the care management that I'll be talking about today, and sharing my experiences. And I guess my objective would be is that hopefully you can feel the passion I have for this type of work. As the slide shows, rather than continuing to fish people out of the river, why do we not look up at the bank of the river and ask, why are they falling into the river in the first place? We're going to be talking about a little about risk stratification. How can we prevent these? How can we proactively identify these patients that are at risk? And then once we do find them, how do we care manage them? And it's a real forward-looking approach to look at which patients will be hospitalized in the near future, within the year. So risk stratification who are our patients, what risk techniques will we use, how will we track them, but what we'll be focusing on today is how we'll work with the patients that we've identified. There are healthy populations that can use primary care support for lifestyle management, community support, well-managed disease, evidence-based, proactive primary care. The poorly controlled disease, which we can do the primary care disease management, and then the complex cases, which we'll be talking about today, which require intensive case management, care management to coordinate care across settings, and then to prevent, hopefully, try to prevent deterioration in their health and prevent hospitalizations. This is the model of Care Management Plus. We participated in the Hartford Foundation grant of evaluating care management and the benefits of it. I think the take-home message on this slide is really that the care managers are the catalyst to really transform the primary care practice. There's a lot of pressure nowadays to transform that primary care practice, and the care manager is really the catalyst to get the team structure, to develop that partnership between the provider, the patient, the family, and the rest of the team. Who will provide care management services? I assume those of you that are on this call have already gone through this process to identify your role, or you're just learning how to identify this role. And let me just tell you, it changes all the time. I look at the past 20 years that I've been doing this type of work, and it has changed and continues to change almost monthly, daily, I don't know. But we'll be talking about how do we identify and stratify those patients. You may already have a registry that shows the patients. In our organization, we receive reports monthly, and on the patients with diabetes that have high risk, that their A1Cs are not in control. They haven't been in to see the physician. The same with asthma. A lot of disease management types of registries that we receive. If you're identifying in the clinic, polypharmacy, studies show that greater than 6 medications on greater than age 65 is an indicator. Multiple chronic illnesses, those complex patients, paired diseases, substance abuse, 2 or more ED visits in 90 days. We receive a daily report that shows the patients that are from our clinic that have been admitted to the hospital, with also the number of times that they've been admitted in the last year. Readmissions in patients within 30 days, diagnosis of cognitive impairment, and of course frequent falls are all signs that how you can risk stratify. Also, with the study that we did with the Hartford Foundation with Care Management Plus, the studies show that about 10% of the population will be in that complex case management group of patients that you'll have. How to identify them? There's really basic 3 levels. The basic is the team. You review them with the team, with the primary care provider, and identify those that are at high risk. And I'll be honest, that works really, really well. We've done studies, and our doctors, our providers at our clinic really are able to go over that list with the care manager and say, I'd like you to meet with this patient. There is an intermediate that have simple algorithms, again with our registries we have, and then the complex algorithms that are tied to complexity scores. For example, stage 4 congestive heart failure. When we identify these patients and whom we should target, we look at the team, we're proactive. Actually asking a patient how they feel is very predictive. their initial assessment if poor, fair, good, or excellent. If they're poor or fair, they may be a good candidate for some care management, education, and support. Patient-centered care of high-risk patients, what made this model that we used was that we were based in the primary care setting. Pretty innovative for 18, 20 years ago, and we made it very team-based and individualized and tried to customize our interventions. Typically, in organizations prior to medical home, whatever the term that you use, ours is personalized primary care, we try to, or organizations try to make the individual fit into our processes. With primary care, patient-centered care, we customize or individualize the interventions to what the patient actually needs, and then hopefully adjust our processes around the patient. It was nice that in my clinic, I have daily interface with the provider. My office is right in the clinic, and if I have a patient come in to see me, I notice that there is a problem with their blood pressure. Perhaps they came to see me about diabetes, and I've noticed that their blood pressure is elevated. I can go right to the provider at that time. I would also say we're screening for depression, and if I notice complications such as that, again, I can go right to the provider. We do have a mental health provider in our clinic, and we also can coordinate right at that point, which leads to the next point, care coordination across settings and providers. When I first started this position, I was referred a patient that had some mental health problems along with some chronic illness, and actually had a family conference and a provider conference. And what we found when we had that conference was that I had 12 different providers in the room with the patient that had never spoken before. Treat the whole patient and the family. We don't just look at a specific illness. We look at the whole patient, what's going on with them physically, socially, emotionally, and so forth. The collaborative goal setting is pretty self-explanatory, actually, but we may have our goals that we want for the patient, and the patient may not be ready for that type. And so we try to meet the patient where they are, getting their feedback and where they would like to start. For example, if we have a patient that has diabetes, they smoke, and they're very inactive, to hit the whole list of goals that we want them to do in our care plan, we're just going to ask them where they want to start. We focus on prevention, wellness, and independence, and I think those three words are the crux of this whole care management process. With the independence, what I look for is if there's a patient that I notice that is becoming dependent on me, then that's a red flag, that I'm not really doing my job the way I should be, that we need to develop that sense of independence, teach them, and we'll talk about that a little bit later. And a big question that we have is to ask is, does the patient have support? Such a big difference in patients that do have family support. An example I have of that is a young man that was referred to me when he was 12 years old, had had a bicycle accident and had a C2 fracture, was on a ventilator, excuse me, and required intensive care. He went home. He has had an amazing family that provided support. This young man went on to get his Eagle Scout, graduate from college, and got a job. But he had an amazing supportive family versus another patient that I was referred about the same time, about the same age, that multiple chronic illnesses, but did not have the family support, had a very chaotic family, and required intensive case management. And I'll be honest, nothing I did made a difference. We'll go to the next. So the ways that you can kind of look at this risk stratification and the care management intervention is with the low-risk groups, group visits. I teach a diabetes class at my clinic, a hypertension class, many phone calls, telephone calls, follow-up, and then I mentioned the classes. With the groups, I have a wellness group that patients that would have wanted to come in and see me every week simply didn't have time to do that. I developed a wellness group, which was a support group basically for patients with diabetes, as well as a group that we have with the mental health provider with patients that have diabetes and depression, that we work with the our mental health provider, our psychologist in our clinic, and he teaches most of the classes. The intermediate is one-on-one, having the patient come in, meet with me one-on-one, and then the intensive care management. These, you really have to engage the team. I do one-on-one appointments. I meet with the patient, with the provider, and occasionally, not often, but do a home visit. Who's on the team? Basically, it's anyone that in your clinic or other healthcare providers that are going to work together to provide the best care for your patient. The primary care physician leads that team, the care manager. In our clinic, our model is we have a care manager and a health advocate who's a medical assistant to work alongside me. Then psychologists, we have 3 psychologists in our clinic that come for about a day and a half a week each. Social workers are from the hospital, but we have access to them. All of the clinic staff, support staff, administrative staff should be there. And then the other healthcare providers. This is where we coordinate care across the settings and providers with cardiologists, dietitians. What I teach patients is that my role is to identify what healthcare team members should be on their team with their support, and then community. And NAMI, the National Alliance for Mental Illness, is a great example of that. Patient-centered care are really relationships that are based on respect and trust. It's that partnership that we try to develop and engage the patient with us. Our role is to be an advocate, to educate, to build relationships and teams, to facilitate team communication, and plan, prioritize, and organize plans of care, and to be very proactive and provide personalized primary care. I think this role, the care manager role, is really 3 types. The first is the detective. What you want to do is to identify the barriers that the patients have and the problems that they're having. Often, I don't think patients wake up in the morning and say, I want to be difficult, and I won't even use the word quote, unquote, non-compliant, because that's not in our vocabulary, but it's our job as care managers to be a detective, to find out what's going on, what information they need, what problems they're having, kind of looking beyond what you see when they present to you, to find out what's happening in their lives to make them have difficulty managing their illness. The next is a salesman, and really to engage them, to show them the benefits and values of health, and then as a coach to educate and support. How do we do the care management assessment? We start with the patient's greatest concern. And another example, they may have been referred to me for hypertension, and I find out that they're caring for their older adult husband that has had a stroke, and they really need help. As actually, that's an example that I did have with her as being referred to me for hypertension, but then when I found out what all of the other things that were going in her life, her hypertension was not her greatest concern. We were able to get support for that family, get home health in, and to help her with her husband. To identify the barriers, fears, and stressors. You know, my patients because we're a primary care clinic, I do deal with patients that have type 1 diabetes, and I would say that the greatest fear that they have, especially the teenage, well, I think all of them, is of going too low. What I see happening is they come to the clinic, they haven't been taking their insulin because they're afraid, excuse me, of hypoglycemia. Their A1Cs go up. We notice that. We up their insulin, and they continue not to take it. But if you can identify the barriers, fears, and stressors that they have, and I might add that anything that they feel is a barrier, and that's a place to start. Of course, the stage of grief that they have, if they're in denial, anger, it's important to recognize that. The readiness to change. We'll talk, I think, a little bit about the readiness to change assessment, but I think the key take-home point with readiness to change, excuse me, I just went up too high, is that if they're in denial and we've identified that they are really not ready to change, we don't just drop them and say, okay, well, we'll catch you when you're ready. We try to use these open-ended questions with motivational interviewing to help move that patient along and help them kind of self-talk themselves into change. Excuse me, the importance and confidence. There's actually a ruler that we can use. How important is it for you to want to manage your diabetes on a scale of 1 to 10? An example I had, I'll give you 2 examples of those, and that is that a patient came in to me, and I used the readiness to change, and he was about a 4. And I said to him, what would it take to move you to a 5 or 6? And he said, I would need to retire. So I asked him when he was going to retire, and that was 2 months later. And I said, let's just schedule an appointment then. We talked, and I'm not exactly sure what we said exactly, but at the end of our visit, he said, do you think I could come in sooner and we could just kind of work on this? But it's using those open-ended questions. Another example I have is a patient that I asked how confident they were that they could manage their diabetes on a scale of 1 to 10, and he said, it's about a 1. And I was able to say, well, why not a 0? And he said to me, I guess there's always hope. Moving on to family pattern profile. This is work that's been done by Brenda Reese-Brennan at Intermountain Healthcare, and it really has, the studies show that from her work is that there are 3 types of ways that families revert when they're in times of stress. The first is chaotic. Those patients wear everyone out. They're calling you all the time, and they're very easy to identify. The care management strategy with those are to give them secure boundaries in your intervention. The secure balanced patient are those that will come to the class, get the information, and come and know when to call you back. And then the avoidant, those are the patients that no-show. They're difficult to engage with, and those are the 3 types of family pattern profiles with some suggestions on how to care management each group. With the avoidant group, you're going to just not give up. You'll try to meet them at the doctor appointment, continue to call them. And then, as I mentioned, that we are screening our patients, every patient that comes into our clinic for depression. And a trigger alert is if the PHQ-9 is greater than 5 or 15. That possibly is a trigger alert for care management for depression. And that may be just linking them into the mental health provider, following along, making sure that they're taking their medications, and so forth. Along with the care manager assessment, of course, cognition, functional ability, learning styles, health literacy, cultural and social issues. This is a quote from Tom Bodenheimer, who has been on the Care Management Advisory Board, and he's nationally known for his work on medical home. Self-management support or health coaching is more than patient education. It involves providing patients with the knowledge, skills, and competence they need to become active participants in their care. I really think it's the care manager is giving the patient confidence that they can manage their care. We talked a little bit earlier about shared decision making and collaborative goal setting, making sure that it's the patient's goal that they want to set. And I might add that it's important when you're working on your care plans that you have to do an assessment before you can just go do a care plan on the patient. Customize or individualize the intervention. Motivate them to seek proper treatment, maintain healthy boundaries. Sometimes with these chronically ill patients, less is best, but it's linking them in and getting your team engaged. Identify the appropriate resources. We have a link at the end of the presentation of the Care Management Plus resources that you can link into. Teach self-management skills. I think an important part is to teach the patient when to call you back. We actually want to empower these patients to take charge of their illness for a lifetime. And ultimately, it's the patient's decision regarding their lifestyle choices. It took me a while to figure that out. As nurses, mothers, nurturers, we tend to want to make everyone better. But what I've had to learn is it is the patient's responsibility. A little bit about how we do patient engagement. And all the studies show that the more engagement a patient has, the greater adherence they have to therapy. Through motivational interviewing, which I believe that you'll be getting in another webinar on motivational interviewing. Motivational interviewing equals engagement. The more proficient at motivational interviewing, the more engagement you have. We have to realize that patients are experts in themselves. A good question to ask is, what help do you feel like you need? That's the place to start. Again, what is your goal? And then ask them, what can we, our provider or care manager, do to help you with your goal? Motivational interviewing is a way of interacting with the patient and families. It involves change talk when the patient begins to talk themselves into change, and it's really asking the right questions, asking open-ended questions such as how, what, tell me more, and you're going to explore what's going on with that patient. Some examples of the open-ended questions: what's your greatest question or concern? The biggest fear that you have? What do you think is wrong? What is your biggest roadblock? What is the most difficult thing about managing your illness? What does it mean, that should be mean, not meal, mean to you to take insulin? And what have you learned from your illness? I recently asked a young woman with type 1 diabetes this question, what have you learned from your illness? And she looked at me and said, I've learned that it's a fatal disease. And actually I was able to start right there to teach her that it wasn't. It's not a fatal disease, and give her the education, identify her barriers and identify the problems that and her biggest concerns that she was having, and to work along. And it was just so interesting to see her transformation. This is a question that I learned fairly recently to ask, do you have other concerns that we haven't discussed? Now that's a question that a care manager can ask. A primary care provider probably doesn't feel like they have time to ask that question because they have 10-minute visits or whatever you have, and it's very limited, which is nice because if they ask that question, they have a team to fall back on, and they can say, I'd like you to meet with my care manager so we can further address these issues that you have. But this old gentleman that is shown in the picture, I had been seeing since I started at my clinic 18 years ago. And diabetes, impeccable control. He came to the wellness group. I saw him probably every 3 months or so individually just to follow up. A1C was 6.4, very, very well controlled. Multiple daily injections of insulin. This picture is that he swam every day at 5:30 in the morning. And he was in one day, and I had just heard about this question, and I asked him that, and he got a little teary, and he said, you know, I think I have PTSD from World War II. Now, I'd seen him for all of those years and never addressed that, never picked up on that he had that. We were able to get him into our mental health care provider, our psychologist, for I think about 3 visits was all, and address this. But that's a big question that care managers have time to ask. It's like a river that when a river is going down the stream and it comes across a boulder, comes upon a boulder, it finds a different way to go around it. As we're working with these patients, that's exactly what we have to do as care managers. If we're running against a roadblock, then we find a different way to approach them, a different question to ask. One of the patients that was in my office, a husband and wife, I asked them what help did he feel like he needed, and he said, and he looked at his wife and said, I need a coach, not an enforcer. If you push, they will push back. So it's trying to find a different approach. And actually, I might add, if you're having a roadblock with your patient and they're resistant to you, you do need to find a different way to approach, a different question to ask. This is the link to the handouts and that we have. There's an in-depth list of resources. You know, nowadays with having smartphones, it's so easy to, while the patient is there, just go on and look for the Alzheimer's Association, any type of it. You can just Google and find it in. But this will give you a link to those resources that there are. What we try to do as care managers is build a bridge from where the patient is to where he or she wants to go. Everyone has a story. Patients want to share their story. Care managers know how to listen and to ask the right questions to help them tell their story. In summary, what patients with chronic illness need: effective treatment, clinical, behavioral, and supportive. They need information and support for self-management, systematic follow-up and assessment, tailored interventions. I might add with that is that care managers have a knowledge of evidence-based guidelines, care process models, and also care managers have a huge role in quality, and then coordination of care across settings and providers. I was listening to the radio, and this actually is a quote. I don't know whom to give credit for, but they were talking about tech jobs, and I thought this applies probably to all jobs nowadays, but especially with care management. It's not if you'll have a job in 10 years, it's how that job will change and how you will adapt to it. With the charge of transforming your practices, it's important to be flexible, to be able to learn new things, to adapt to it, and to really take this job. And it's an opportunity for innovation, to think out of the box, to really identify how you can make a difference in these patients' lives. And Kate, I'll turn it back over to you.
Great, thanks, Dan. So just a reminder to everyone, you are on mute. If you want to, we have a few questions that we'll address right out of the gate here, but if you have some questions for Ann, go ahead and type those. If you would like to ask your question over the phone line, make sure you've entered your audio pin so that I can unmute you. Your audio pin, if you haven't entered it, is listed in the audio portion of the GoToWebinar control panel. And just indicate in your typed question or message me and let me know you'd like to ask over the phone line. But before we get to some of the more involved questions, Ann, there were two really quick ones. At the beginning of the presentation, when you were talking about risk stratifying patients, you referred to a paired disease. Can you explain what that refers to?
Sure. A paired disease is like congestive heart failure and diabetes. It's the complex patients. It's those that have one or more, well, paired would indicate two, but complex illnesses, multiple diseases.
Okay, great. And then the other quick question was, what is the size of your panel of patients?
It's around 350 patients. Now, not all of those are being actively care managed at the time. Again, I'm trying to teach the patients when to call me back. I do a lot with groups, group diabetes education, other types of education, but around 300 probably.
Okay, and then this one's a little more involved, but could you share with everyone the workflow on how patients get referred to you and your caseload, and then also the criteria for graduating patients out of care management?
Yes. So the workflow, and the majority of my patients came and do come from physician referral. Now, we do, for example, a patient is visiting the provider. They identify the the provider identifies that they would like the patient to have care management, and we have an end of visit form that the doctor simply marks, refer to care management, and then there's a reason, and the patient takes this to the checkout as they make their next appointment. We have a scheduling coordinator that identifies that the patient's been referred to me. We have, of course, the electronic medical record, our messaging system. The scheduling coordinator then messages me that this patient needs an appointment, and if it's for a class, they automatically schedule that patient for my next available class, which in our region, we teach a diabetes class once a week. And there are 4 care managers, so each of us teach a diabetes class every day of the week. It's also an automatic referral for the classes, the diabetes classes at the hospital, and an automatic referral to the dietitian, who is not on site, but we're actually looking at possibly having a dietitian come on site at our clinic. But so that's an automatic referral. So the end of visit form, the scheduling coordinator messages me. Some appointments are already scheduled by the scheduling coordinator, for example, the classes, and then the scheduling coordinator will send me a message saying, Dr. So-and-so has referred this patient to you for this reason. And it's in our queue, and I look at that, then I call the patient, schedule them, and I might add, I can guesstimate the amount of time that a new patient, I always schedule about an hour visit for a new patient. The other visits are probably around 30, 40 minutes follow-up as I meet with them for follow-up, which I do schedule myself. But that's the process that I get for referrals. And basically it's physician referral. However, now we do have our registries. And as we're reviewing the registries, I look to see patients that A1Cs have increased, and I simply call the patient. The script that I use when I call patients to schedule any appointment is, Dr. Wenzel asked, I'm the care manager at the clinic. Dr. Wenzel asked me to call you to schedule an appointment to see if you'd like help with your asthma or with your diabetes or whatever. And it's that validation. Warm referrals are wonderful, not always practical. If I'm in the clinic, the doctor may come down and say, I would like you to come and meet this patient. When that happens, the engagement with the care manager and the patient is very, very high. Success of making that work. I would say that's probably the exception that we have time to do that. We mainly do the end of visit form and do that. Now, did that answer all of the questions?
I think the one last part was, well, and then there was another follow-up question too. So the criteria for graduating patients, and then the other follow-up was, with a panel of about 300, how often do you touch or connect with the patients, and how do you keep track of them?
Yeah, we have, so how do they graduate? You know, again, I go back to the work by Brenda Reese-Brennan, that the family pattern profile. Those that are secure balanced, which actually are going to be about 80% of your practice. So as that one slide showed on how many are complex. So about 80% of at least my practice. Now, that's how we've been doing, and it's actually changing now too. So, but let me answer that. So 80% are going to be in the secure balanced group, and they come to the class, they get the information. I usually schedule a follow-up visit following that class in about a month to see how they're doing, and they take the information and they run with it. The avoidant ones, I am trying to do whatever I can do to engage with that patient, meet them at the appointment with the provider, look and see when their next appointment is, tell the doctor I'm having trouble, you know, getting with this patient, and do whatever I can to try and meet with them. The chaotic ones are the ones that are going to require more of my time. Again, strong boundaries, less is best. An example might be of that is we had a patient that was calling in every single day, and we found out all the barriers that she was having, which I won't go into now, but we actually scheduled a time for me to call her, and to say, you know, I was able to say, you know, Dr. Obayashi wants to meet with you every other month. He would like me to meet with you every month, but I'd like to schedule a phone call appointment with you so you'll know when I'm calling every week, so that you can make a list of your concerns, and we can address your concerns. Dramatically decrease the amount of time that numbers of times that she was calling the clinic, just knowing that she had someone to support, and that we were actually addressing her. So when do they graduate? When they're stable, and when they, you know, their A1Cs have come down. I would say the majority of patients have, and the study actually proved this when we did in-depth documentation when we were being studied. We knew that care management worked, and we wanted to prove it. So the care managers, as we were being evaluated, we had and have a care management documentation system, and we wrote down everything: phone calls, appointments, visits. What that study showed was that most of the interventions were 2 or 3 visits, and that's all they needed. Now, there were some, as I mentioned earlier, that I met with monthly for several years. But I also tried to get those patients into one of my groups so that I was seeing them monthly in a group, and then maybe every 3 to 4 months individually. And I had to do that because of the time and the numbers of referrals that I got. So, you know, you have to be smart about when they're being discharged. I know there are, probably you have criteria in your organizations. I know our health plans have stricter criteria of when a patient will be discharged. I had the freedom and the flexibility of kind of letting the patient decide, actually, along with me, knowing that if they were becoming dependent on me, that was a problem, and I wanted to promote independence and self-management. So I know that really isn't a specific answer, but I guess I don't really have one for that. But the best I could say is that when their A1Cs are in control, or their insulin is stable, or their disease is managed, and they have the knowledge and self-management ability, then I would discharge them, but I would teach them when to call back.
Okay, great. We have a few more questions, and so hopefully we'll have time to get to all of these. The next one is, if we have 10 RNs that we would like to train to be case managers, what is the best way and place to start?
That is a great question. With Care Management Plus, we have provided training to care managers across the country. And I think we've trained about 300 different clinics. It's a 2-day workshop that talks about roles and responsibilities. There's a lot of teamwork, engagement, and then the second day is a lot of motivational interviewing. As far as how to train them, I think it is, you know, along with Care Management Plus, they have an online portion that goes through disease management. There's also, with Health Sciences University, there is a registered, I've got that book right here. It's, you can Google Health Sciences Institute. There's a certified health coach, and it's chronic care professional, the CCP health coaching certification manual. There, of course, are a CCM, a care management certification. I think the best way, let me tell you what I did when I first started. Again, this was 20 years ago when it was just being invented, I guess. What I did was, this is more not really how, you know, so to train care managers, they need knowledge in the care process models that you're using, the diabetes, the depression, the asthma. It's, what I was going to go into, it's engaging your clinic, having support from administration to identify your role. It's knowing what the goals are, which are really to, we talked about that, promote adherence. I won't go into all of those again. But it's having the knowledge of the care process guidelines. It's looking at your organization and finding out what's important to them. For example, my role kind of, it started with that as, I'll tell you, when I first started, it was working with high-risk patients and having the medically complex high-risk patients and having doctors say to me, I need to meet with this patient to find out what's going on, and linking them into resources. That's how it started. There are now many programs, and if you go into the Care Management Plus, there's the online portion training, which provides different modules for care management. What I did when I first started was I did a one-page summary, and I met with I scheduled, when I moved to my clinic, I scheduled a 10-minute appointment with each provider. They don't have a lot of time. They don't want to hear they want just concise, few sentences, why I'm here, what I hope to be able to do. And I think the biggest thing is to save the physician time. It's to ask those questions that providers don't have time to ask. It's to look beyond and find out what's going on with the patient. And then it's to identify the right resources will help them and to follow up. To identify a physician champion in your clinic. Don't worry if all of your providers aren't on board at the same time, because if they were, you would be overwhelmed. It's to start, and all it takes is one good intervention that you've got with a patient, and I might add, it takes time to develop the relationships with the patients, with the providers. It's, we talk about assessing patients, but we're also assessing providers and what they want from us, and ask, what's the biggest thing I could help you with? And if it's your patients with diabetes, if it's the patients that are older adults at risk for fall, it's getting the appropriate resources into the home to help assess those. And then the other thing I did is when to refer, who to refer, and then how to refer patients to me. Education, we received a lot of education on disease management, but I would say see what your organization is focusing on and then hone in on that, what patients they want you to start with.
Okay, so Anne, we'll probably have time for about 2 more questions, which is great because we have 2 good ones. The first one is, are you using interactive care plans in your EHR for these patients?
Yes, we are. Of course, with NCQA and all of the guidelines that we have, that is a huge focus, is documentation and documenting a care plan. The aspects of the care plan that we have is we have, of course, the treatment guidelines that we give the patients. I'm just going to kind of go down the list of the care plans that we're using. And so this would be one for diabetes. And at the top of the care plan, I have a brief summary of my visit, so the doctor can see that. I have next the goals that the patient has selected. Now those really come at the end. I've moved them to the front so the doctor has, or the provider can see what we're working on with that. Then we give them a copy of the treatment guidelines. For example, in the diabetes class, I'm teaching them the standards of care, when they should have their A1Cs done, all of those, and they get that, and that's checked. They get a summary. We have a patient worksheet, which is a summary of the visit that they have, has their problem list, their medications, their labs. I'm reviewing that with each patient when they come in, and they get a copy of that. That's another check. We're evaluating their self-management ability with readiness to change, their importance and confidence scale, and then asking them, what could we do to help you with your goal? And then we have a menu of options for them to look at, self-care goals that are already on the care plan that they can choose from, where to start. Would they like to, focus on taking their medications regularly, do 30 minutes of exercise 30 minutes a day, etc. Really, getting their flu vaccination yearly, checking their feet every day, reducing their risks, for example, smoking. But those are goals that they're looking at, and depending on where they are, and let them choose what they would like to do. We're also documenting the referral or the resources or referrals that we've given them. And then if there's any other, our education materials, we're documenting that if they were referred to a dietitian. And then we have a a handout, a printout of the community or other referrals, for example, websites that they can go to. So that's what our care plan looks like. And we're updating it, as they come in to see us. Again, I want to stress you have to do an assessment before you can do a care plan. But and part of that assessment is the open-ended questions that we asked earlier, their biggest source of stress, identifying the appropriate ways to engage with them, their learning style, looking at barriers, and those other nursing assessment questions, depression, do they have support? So I think I probably don't have time to go into any more detail on the care plan, but we are doing care plans. That's a huge part of what we do now, and that has changed. It's getting it documented for the medical home certification.
Great. There's probably time for this one last question. So there is a question about more information about the family pattern profiles, like maybe is there a link to that information that we could share? So I don't know, Ann, if there's maybe a document or something you could send to me or a link that I could then post with the webinar materials?
Absolutely. You bet. You could go to intermountainhealthcare.org and look up Brenda Reese-Brennan and her work, but I can also send you a link to that. One thing I didn't mention on that is how do you identify these patients? Now, she's done lots of work. There's a huge, big assessment, but basically it's one question you can ask your patient and to identify those three types. The question is, whom do you talk to when you're feeling ill, distressed, or having problems? So if they talk to no one, they're avoidant. And again, the care management intervention is you try to meet them at the appointment. You don't give up. You try to engage with them, do whatever you can. And I might add, when you finally do get them in, to add further engagement with that patient. So you've got them in your office or you've met them at the doctor appointment, and you simply say to them, it must be very uncomfortable for you to have to come and see me and visit with me. And it's like a wall just kind of goes down, and they go, yeah, you get it. It really is uncomfortable for me. So the secure balance question is, on whom do you talk to? Do they have support? Do they have a family member, someone that they can talk to? Those are the secure balance. They're going to take your information and they're going to run with it. You're going to see them maybe once or twice. They won't need a lot of follow-up. You're teaching them, and they will call you back when they're having problems. The most difficult group to work with is the chaotic. And the question, whom do you talk to? Well, they're talking to everyone. They've burned out all of their resources. They're calling the clinic every day. They're calling you all the time. Very easy to identify these patients. They have a lot of chaos in their life. Again, the intervention is structure. It's having them know that you're there, but you're putting boundaries on I guess, their behavior, actually, but you're helping them. But you're also letting them know that you're there, but you're providing those boundaries. So, in answer, yeah, I'll send you a link to her work, and it's fabulous. It's transformed how motivational interviewing and the family pattern profile, learning how to ask the right questions, learning how my interaction and how I feel towards a patient, which you learn with the family pattern profile, is invaluable in care management and helping to manage these chronically ill, complex patients.
Great, and so I will include, so just a reminder to everyone, an email will come to you from GoToWebinar tomorrow with the slides, a link to the recording, and I'll also make sure that that link that takes you to the Institute site that we list on there, some of the other links that Ann's referred to today, including the family pattern profiles that we were just talking about. So we're going to go ahead and wrap up since it's 9 o'clock, and I know you all have things to go on and do. Just in closing, a survey will pop up after this presentation. If you could fill it out, that would be most helpful. Again, the materials will come to you via email, or you can visit the Institute site later. And if you have additional feedback or questions, you can always go ahead and email us. Thanks so much to Anne for joining us today, and for you all for taking some time to hear what she has to say. And thanks a lot. Have a good rest of your day.
Thanks, Kate.
Bye.